Test 1, 2, 3. Good morning, the subcommittee will come to order. Before we proceed, I would like to ask unanimous consent that Representative McMorris-Rogers and Representative Schneider be permitted to participate in this hearing. Without objection, so ordered. I want to welcome our witnesses back to discuss VA's continued struggles with the Oracle Cerner pharmacy software. I want to thank Ranking Member Surplus McCormick for proposing that we return to this subject. The situation we found in our previous hearing in May of last year was dangerous and unsustainable, and it seems much the same today. Simply put, the medical centers using the Oracle Cerner EHR have been turned upside down. They've had to increase their pharmacy staffing by at least 20% to navigate all the bugs and workarounds just to process roughly the same volume of prescriptions. The cost, millions of dollars, but these are just 5 small, medium-sized hospitals. VA projects that large, complex medical centers will have to increase their pharmacy staffing by as much as 60% to navigate the software's problems. If the EHR was implemented throughout the Veterans Health Administration, those personnel costs would quickly run into the hundreds of millions of dollars. That's money that could otherwise fund veterans' health care, fight homelessness, or renovate aging hospitals. And it's all to prop up a system that is clearly inferior to what the VA has today, which is Vista. On top of the added cost, it creates a dangerous situation. Nearly 20% of the patient safety reports from the 5 medical centers are related to the pharmacy. OIG has come forward with alarming new findings. Mr. Case's office discovered widespread errors in VA's internal drug codes and the health data repository. When veterans are treated at a facility using the Oracle EHR and then treated at a facility using Vista, their medication information may be incorrect. That means drug-to-drug interaction checks and allergy checks may be based on inaccurate information. According to the OIG, this problem may affect at least 250,000 veterans, and it's been going on for years. In one incident that OIG documented, a veteran in a VA residential treatment facility was repeatedly denied his medication because it was showing inactive in the system. It took 5 days for the veteran to convince the staff that he needed the medication. But by then, he was in danger and had to be transferred to the emergency room. And that's just one. We've got 250,000 veterans that have been having these problems with the pharmacy. An Oracle software update last April corrected some of the system errors, but there is still no solution to many of the others. However, VA still hasn't notified any of the veterans who were impacted or are still being impacted. Apparently, the VA has been hiding this problem. According to the OIG, the department took no action to go back and correct the veterans' medication information in the health data repository after the April software update resolved the underlying error. But instead, the VA has been quietly waiting for the prescriptions to expire and the inaccurate medication information to fall out of the back end of this database. And VA seems to have been concealing the errors that are still ongoing. This is a breach of trust, and it's absolutely unacceptable. I question what other dangerous pharmacy problems have not even been uncovered yet. What we do know is that the results of the VA and Oracle strategy to improve the EHR have been one step forward and one step backwards. We're not gaining on this. 2.5 years ago, the pharmacists in the field created a list of 79 problems with the pharmacy software. VA prioritized 7 of the 79, and Oracle rolled out fixes over a series of software updates. The most recent, called Block 10, happened a few days ago. The most important fix aimed to eliminate the confusing, error-prone double entry process in the core EHR pharmacy software and medication manager retail, which is used for the mail, outpatient pharmacies, and community care. This originally went live in April of 2023, software update, but the VA had to immediately roll it back because it caused yet another problem with dosage instructions getting lost. The fix was supposed to happen again a few days ago, but it was postponed due to testing problems. This particular item demonstrates the larger issue. These are piecemeal, painfully slow improvements to software that seem to be fundamentally inferior to Vista. Is anybody starting to hear this reoccurring theme? And they involve VA paying Oracle most of the cost to overhaul the system that the VA already bought. And this is the complaint that I have had from the very beginning. This is a firm, this is a corporation that continues to get enriched by trying to develop a program at the taxpayers' and the veterans' expense. They're being used as guinea pigs, and everyone else on this committee recognizes it. Even worse, many of the changes introduce new complications, unexpected errors, and safety risks that the pharmacists have to manage with yet more workarounds. The VA pharmacists are telling us very clearly that they're fed up, and they cannot do this forever. We are way past piecemeal solutions, and we are not going to tolerate the VA sweeping any more dangerous errors under the rug. The definition of insanity is doing the same thing over and over again while expecting a different outcome, a different result. I have come to believe that this continuing effort to transform the Oracle Cerner pharmacy software into something completely different is insanity. Okay. With that, I conclude my remarks. Representative Sheriff McCormick, are you prepared to?
Can you defer and start with the witnesses?
Sure. Okay, we're going to jump in with the witnesses. First, we have to, where's my swearing? Okay, we're going to introduce them. Okay. I will now introduce the witnesses on our first and only panel today. First, from the Department of Veterans Affairs, we have Dr. Neil Evans, the Acting Executive Director of the Electronic Health Record Modernization Integration Office. We also have Dr. Thomas Emmendorfer, the Executive Director of Pharmacy Benefits Management Services, and Dr. Robert Silverman, the Chairman of the EHRM Pharmacy Council. Next, from the VA Office of Inspector General, we have Deputy Inspector General David Case. Finally, from Oracle, we have Mr. Mike Cecilia, Executive Vice President for Global Industries. Gentlemen, if you would please stand. I ask the witnesses to stand and raise your right hands. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you, and let the record reflect that all witnesses have answered in the affirmative. Dr. Evans, you're now recognized for 5 minutes to deliver your opening statement on behalf of the VA.
Chairman Rosendale, Ranking Member Sheriff McCormick, and distinguished members of the subcommittee, thank you for this opportunity to testify in support of VA's initiative to modernize its electronic health record system. As has been mentioned, I'm accompanied by Dr. Thomas Emmendorfer, our Executive Director for Pharmacy Benefits Management, and Dr. Rob Silverman, our Pharmacy Council Co-Chair for the electronic health record modernization effort. Before I speak to pharmacy directly, the focus area for this hearing, I'd like to take a moment to reflect on the EHR modernization program more broadly, specifically the program reset that we announced in April of 2023. As you know, having listened to veterans, VA staff, and Congress, including this subcommittee, VA stopped work on future deployments of the federal EHR, except for the upcoming deployment at the James A. Lovell Federal Health Care Center. VA did this to prioritize improvements in support of more than 10,000 users at 5 medical centers, 22 clinics, and 52 remote sites using the new system, and to optimize VA's enterprise readiness to successfully resume deployments at a pace conducive to a complete and successful rollout. As we've said before, we're committed to getting this right. Even beyond the benefits of a shared record with our federal partners, within VA itself, transitioning to a single instance, enterprise-wide electronic health record will provide significant value, allowing easier visibility of a veteran's complete health record regardless of where they receive care, allowing standardization of clinical and business processes across the VA enterprise, reducing variation and increasing the consistency of care delivery, and allowing for better sharing of clinical resources and expertise across VA's regional and national networks. The Lovell Federal Healthcare Center in North Chicago, Illinois, a jointly run VA and DoD facility, has been another priority for us during the current program reset. This is the final deployment of the federal EHR at a DoD site and will also be the first VA deployment at a larger and more complex VA healthcare facility. We're still on track to go live at FHCC in early March. Let's transition now to the focus of this hearing, the pharmacy software capabilities being implemented as part of the federal EHR. Improving pharmacy functionality includes addressing the needs of 3 key stakeholders in both the inpatient and the outpatient settings. VA clinicians who are prescribing pharmaceuticals and counseling veterans about how those medications fit in their overall care. VA pharmacists and the pharmacy staff who fulfill those prescriptions, manage pharmacy inventory, back-end pharmacy processes, while also providing valuable counsel to veterans. And of course, the veterans themselves, as they access their prescriptions, refills, and more. The scale of VA's pharmacy operations is also worth noting. On the outpatient side alone, VA pharmacists and staff manage upwards of 146 million prescriptions each year, and VA's mail fulfillment services reach more than 350,000 veterans every day. Unlike many other healthcare systems, VA pharmacists and pharmacy staff are fully integrated into patient care teams, both inpatient and outpatient. The division that exists between the health system and retail pharmacies in the private sector simply doesn't exist in VA. In part because of the uniqueness of VA's pharmacy care delivery model, and in part based on lessons learned since our initial implementation of the Oracle Health Record at the Mann Grandstaff VA Medical Center in Spokane, we've been working to continuously improve the Oracle Health software solutions and VA pharmacy operations as they leverage the new software. Over a year ago, the EHRM Pharmacy Council, along with Oracle Health, helped identify critical early items to be sequentially addressed through code upgrades, which are delivered through joint VA-DoD block releases. Improvements have been delivered in each of the last 3 block upgrades, blocks 8, 9, and 10 in February and August 2023, and finally, as has been mentioned, this past weekend. So where are we? We've made incremental but steady progress. The most significant improvements have been realized in system performance and in the clinician ordering experience. There have also been several enhancements delivered to improve the pharmacy fulfillment process, but this is an area where further work remains to enable increased efficiency for pharmacy staff. As of today, all but one of the initially identified priority enhancements have been delivered. The final feature, which will automate the synchronization of prescription information between the Oracle provider and pharmacy applications, has been installed, but is not yet enabled. Both Oracle and VA recognize that we're not yet done. As I already mentioned, an area of considerable focus will be increasing how efficiently pharmacists and pharmacy techs can complete necessary tasks within the software suite, among other improvements. In conclusion, VA pharmacists, providers, and veterans alike deserve a system, including ongoing enhancements, that performs as promised and continues to keep pace with their unique demands. My expectation is that this will continue to be a shared priority for both VA and Oracle, and that Oracle will remain committed to their promises, including those made in front of this subcommittee, to prioritize and accelerate the work on pharmacy matters. Thank you again for the opportunity to testify today.
Thank you, Dr. Evans, and the written statement of Dr. Evans will be entered into the hearing record. Mr. Case, you're now recognized for 5 minutes to deliver your opening statement.
Chairman Rosendale, Ranking Member Sherfulus McCormick, and subcommittee members, thank you for the opportunity to discuss the OIG's oversight of the new EHR's pharmacy functions. Since April 2020, we have published 16 reports on EHRM. 9 of them related to significant patient safety concerns, such as issues with medication management, pharmacy software, and patient care coordination. I will discuss 3 upcoming draft reports that are currently under review at VA, consistent with our report process. While we do not usually discuss reports before publication, due to this hearing's timing, I will generally describe our findings. First, an OIG team reviewed pharmacy-related patient safety issues facing every VHA provider. VA has corrected one of a series of issues related to the transmission of inaccurate medication information into a database called the HDR, which stores clinical information about every patient's medications and allergies. However, we are concerned about unresolved and insufficiently communicated pharmacy-related patient safety issues. Legacy EHR sites may have inaccurate medication information for patients treated at both legacy and new EHR sites. We believe Ermio and Oracle did not test for medication and allergy data accuracy after that information was transmitted to the HDR from new EHR sites. Thus, patients seen at both new and legacy EHR sites may be prescribed contraindicated medications, and legacy EHR providers may be making clinical decisions based on inaccurate data. My written statement discusses a veteran who had a delay in receiving critical medication due to this issue. As of September 2023, there have been approximately 250,000 veterans who either received medication orders and/or had medication allergies documented in the new EHR. They may be unaware of the potential risk for a medication or allergy-related event if they visit a legacy EHR site. While VA is taking efforts to reduce this potential, we remain concerned that patients have not been informed of their individual risk, essentially being excluded as full participants in their care. Nor have we seen evidence that VA has sufficiently notified legacy EHR providers about this issue and the mitigations to safely care for these new EHR site patients. While legacy site leaders were told to have providers perform manual medication safety checks to replace the automated checks for new EHR patients, these manual safety checks are complex and rely on the vigilance of pharmacists and frontline staff. At Columbus, we found a prescription backlog required a permanent 62% increase in clinical pharmacists. Pharmacy leaders had to create their own workarounds and education materials, and pharmacy staff were burned out and had low morale. These findings are troubling given the mitigations for pharmacy failures rely on staff vigilance. Although unrelated to pharmacy, I wanted to alert you to 2 other upcoming OIG reports on scheduling, which also address issues requiring high levels of staff vigilance and inadequate mitigations. The first addresses problems with the displaced appointment queue that can cause staff to not handle appointments needing to be rescheduled when a provider's schedule changes. Schedulers report appointments do not always route to the queue and may disappear from it. Ermio told us that February and April updates would address these defects. Further, the new EHR still cannot switch an appointment time between in-person, VA Video Connect, or telehealth without the scheduler canceling the appointment and the provider ordering a new appointment, creating a burden on both. The last report, VHA is allowing mental health staff at new EHR sites to make 2 fewer attempts to contact no-show patients compared to legacy sites. This procedure creates a different standard of care, a disparity among veterans at new and legacy sites. VHA should address administrative barriers created by software deficiencies without compromising patient care and engagement standards. In conclusion, EHRM's success is dependent on VA's transparency, careful planning, and the recognition and remediation of plant safety issues. Additionally, trust in VA is contingent on patients and providers being fully and quickly advised when issues are identified. Chairman Rosendale, this concludes my statement. I would be happy to answer any questions you or other members may have.
Thank you very much, Mr. Case. The written statement of Mr. Case will be entered into the hearing record. Mr. Celia, you're now recognized for 5 minutes to deliver your opening statement.
Chairman Rosendale, Ranking Member Sherfless McCormick, and members of the subcommittee, thank you for inviting me here today. At the 5 live VA medical centers and their associated facilities, veterans are receiving their outpatient prescriptions at the pharmacy window in an average of 25 minutes for January 2024, which is below VA's 30-minute key performance metric. On average, more than 215,000 outpatient prescriptions are being filled each month. The current live sites do not have a backlog in filling prescriptions. Since the first deployment in October 2020, 4.3 million prescriptions have been filled through VA's mail pharmacy. This number of prescriptions is in line with historic prescription fill volumes. Veterans are receiving their medication in a timely manner. We know that VA has increased pharmacy staffing, and we continue to partner with VA to find efficiency opportunities while maintaining the benefits of the new capabilities. Some tasks, like reviewing the warning information on an allergy or drug interaction and marking it as reviewed, may take a little longer, but also provide enhanced safety protocols. We are also aware that VA is considering additional enhancements that may further adapt the system to VA's unique pharmacy needs. We have already delivered 7 enhancements, 6 of which are live today, that adapt the pharmacy system to a more bi-directional system between providers and pharmacists. As you're aware, the VA pharmacy processes are different from most of the commercial sector. We remain confident that our work to update the entire EHR system, including pharmacy, to a modern, stateless web application, along with moving the EHR system to the cloud, will provide a basis for a much more user-friendly interface and experience. New stateless web technology is already in the hands of our commercial customers in beta format, with general availability planned for later this year. Finally, we know that the work being done now with VA to standardize and simplify workflows and procedures will pay dividends in improving the overall pharmacy and EHRM experience. We acknowledge that for these early sites, pharmacy has been challenging. Shortly after the acquisition in June 22, when I came to the Hill and met with congressional stakeholders on EHRM, improving pharmacy was one of the top complaints I heard. We listened, received the required changes on contract from VA, and delivered them in an expedited fashion. When the Lovell Federal Healthcare Clinic in North Chicago goes live next month, the providers and pharmacists there will start using the system with the current enhancements. They will also start with much improved training. During a visit last week by VA and the Oracle team to Lovell, feedback from pharmacists was positive about the training and readiness for using the new pharmacy system. We are anxious to evaluate the deployment and get feedback from the pharmacists at Lovell. It will provide valuable insight, along with the continued review of the feedback from other live sites, for other enhancements that may be required as we seek to continually improve the system. Oracle looks forward to continuing to provide VA with a pharmacy module in the new EHR that enables veterans to receive their medication when they need it and safely. Thank you.
Thank you, Mr. Cecilio, for your comments. The written statement of Mr. Cecilio will be entered into the hearing record. I will now recognize Representative Sherfless McCormick for opening statements.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today to discuss what progress has been made to fix the issues with Oracle Cerner's pharmacy application. It has now been over 3 years since Cerner Millennium was deployed at Mann Grandstaff, Virginia Medical Center. In that time, we have continually heard from VA providers, the Inspector General, and the Government Accountability Office about issues with the system that have put veterans at risk and made VA employees' jobs unbearable. The new EHR has required a Herculean effort to ensure that veterans receive safe health care, which has had a dramatically negative effect on employee satisfaction. Late April, VA finally listened to those concerns and to the concerns raised by the committee and undertook a reset of that program. I applaud that reset during our pharmacy hearing last May, and I still applaud it. However, I'm extremely concerned about the fact that VA and DoD plan to deploy the system at the Captain James A. Lovell Federal Healthcare Center next month, before the objectives of the reset have been met. In December, committee staff traveled to Lovell to meet with leadership and frontline staff. It was clear then that the VA providers were not convinced that the software was ready. In fact, Lovell's pharmacy leadership indicated that they didn't feel like anything had changed. While I understand that the DoD is motivated to finish its deployment, that cannot come at the expense of our veterans or VA providers. I hope the VA's decision makers are being incredibly deliberative in deciding whether or not to go live should be allowed to happen as scheduled. In an effort to address some of these issues plaguing the system, Oracle Cerner and VA deployed the much-awaited Block 10 upgrade this past weekend. I understand that there were some major pharmaceutical enhancements expected to be delivered with it, but not all of them were working correctly, and some of them deployed without even being turned on. I hope to hear about VA and Oracle's plan to fix the issues and their timeline for turning them on. As for the rest of the upgrade, it probably too early to know for sure, but I hope to hear how it went and how VA is going to measure the impact of those changes. VA providers have been struggling far too long under the weight of the mitigation efforts. I'm still optimistic that there is a path to success for this project, but not without major changes to the way the VA has been managing it. That is why I, along with Chairman Boss, co-sponsored Ranking Member Takano's EHR Program Reset Act last Congress and am still working with my colleagues across the aisle to ensure that we put adequate rail guards around VA's work. I look forward to hearing from our witnesses today, and I yield back, Mr. Chairman.
Thank you very much, Representative Surplus McCormick. We're now going to proceed to questioning, and I recognize myself for 5 minutes. Mr. Case, your office uncovered a multitude of pharmacy problems. Will you please explain how the errors involving the health data repository and the medication identifiers work, and how they can cause veterans' drug-to-drug interaction and drug allergy checks to be inaccurate?
Yes, sir. Start with the health data repository, or HDR, which stores clinical information for all VHA patients, including a unique identifier referred to as a VUID for any medication. A veteran getting a prescription at a new EHR site, after the prescription is filled, the system sends the prescription data, including the VUID, to the HDR. If that veteran goes to a legacy or VISTA site and receives a new prescription, another program in VISTA accesses the HDR to perform a safety check and make sure the medications prescribed at the legacy site are compatible with the prescriptions from the new EHR site. It was discovered that when the legacy system goes to access information from the HDR, there are times that the medication information in the HDR from the new EHR would not be accurate or could be duplicative or simply missing. And so the result is, when this check occurs, when a veteran has gone to the new EHR and is now at the old EHR getting prescription, it could be based on inaccurate information.
So, Mr. Case, what happens when a drug interaction check or a drug allergy check is based on the wrong medication?
So when a medication check is based on wrong information, you could prescribe, or a provider could prescribe, a medication that is contraindicated, meaning there may be side effects, there may be less efficacy to one or more medications.
So when we hear Mr. Cecilia talking about all of the medications that are going out and being delivered, if they're not the proper medications, or there could be interaction problems between the medications that are being delivered to the veteran, have we really accomplished anything?
Right. As I understand the data referred to earlier, he's talking about prescriptions at the new EHR sites, and that information will be accurate when you compare new information or information from a new EHR for prescription 1 to prescription 2. The risk occurs when there's a prescription at a new EHR, and veterans, snowbirds, people travel, they get their health care at old sites as well as new EHR sites. So when they travel and go to an old site and a new prescription is done, that's when the risk occurs.
Exactly. So again, is it more important to have a number of prescriptions being delivered, or make sure that the number of prescriptions is accurate?
The most important thing in our mind is patient safety.
Thank you. Mr. Case, how did you determine the 2 patient populations that may be impacted, and how did you come up with that total of 250,000 unique veterans?
Yes, that number was provided to us by VHA, and those populations of unique patients at new HR sites who had prescribed medication and or documented allergies. So that 250 is the ones that are at risk if they go to a legacy EHR.
And Mr. Case, those numbers are based on information the VA gave you in September 2023, correct?
That is correct.
Okay, do you have any idea how many veterans may be impacted today?
We do not know how that number has been modified. We're not aware of what actions have been taken by VA since our report. So VA is in the best position to update that number.
Okay, so we still could have many more than the 250,000. Mr. Cecilia, according to the OIG, Oracle built the interface to the health data repository that contained the coding error, and Oracle corrected one of the group of errors in April of 2023. But the other group of errors has not been fixed and continues as we speak. Is any part of that inaccurate?
My understanding is that we have delivered 10 fixes, 10 data files to HDR to correct the database between May of 2023 and November of 2023, which corrects the drug interaction and potential duplication checks within the VA.
So why do I hear about the system that was just introduced 3 days ago that was actually pulled right back off again to help address this problem, if a problem has already been addressed?
There was a final testing check that did not pass, and
So in other words, we're still working on the same problem that you're trying to tell me that was resolved last year?
there was another issue that surfaced in the testing of one of the 7 enhancements that was fixed again last night. The testing begins today. In the interest of patient safety, we decided, of course, not to roll out anything that did not pass all final safety checks.
Sure. Mr. Case, please help me to understand this, because Mr. Cecilia seems to think that the fixes that they rolled out last year resolved this problem, and yet the one that he's trying to roll out here within the last 3 days is to address the same problem. I'm confused. Could you clarify?
Right. The Block 10 addresses a set of issues that they've identified, among others, in pharmacy. What we've identified in our report has been ongoing, and to our understanding, there is no fix. That's the risk when a patient gets prescriptions at a new EHR, then goes to a legacy EHR site, and the fact that there may be inaccurate information in the HDR from the new EHR is still extant unless it's been fixed in September when we got our data.
Thank you very much. I will now recognize Representative Sherfless McCormick for 5 minutes questioning.
Thank you, Mr. Chairman. Mr. Cecilia, during our last hearing on the pharmacy issues, we discussed the corrupted data going into the health data repository and how it was impacting VA's ability to prevent dangerous drug interactions and allergies. Why wasn't this issue caught in testing before the interface was turned on?
Thank you very much for the question. It is a good question. The testing around this process is very manual. It's very rigorous, and when we become aware of these issues and things like this happen, we did fix these issues immediately and stop any deployment of anything until this was fixed. So why it actually was not caught, I'm not exactly sure. I'm happy to reply back in writing as to what corrective actions have been taken. But that combination of testing involves Oracle, it involves the VA, it involves the pharmacy councils, and I'm not exactly sure on that particular issue where the breakdown was. But once it was discovered, we did fix it, and we did offer fixes to the VA immediately.
So do you believe that there's an issue with the fixing the testing process?
I don't believe that there's a core issue with the testing process. I think the issue is that there are a lot of manual checks, meaning that human beings have to be involved in testing. Typically, you want to try to automate as much of that testing, particularly for interfaces, as you possibly can. And I think we continue to work together with VA to make that process more efficient. And I think the fact that what we saw happen in these last couple days, where we did not deploy something because it did not pass a test, is a testament to a much better testing process. You obviously do not want to deploy something and then find an issue after it's deployed. Much rather, in the interest of patient safety, not deploy something that does not pass a particular safety check. That's exactly what happened. We got the feedback, we redeployed that, and again, as I said, that has now been addressed last night. Testing will continue for the next 2 weeks.
So are you making any accommodations or alterations to ensure that future issues are caught before they're deployed?
We are, and I think that, again, not to be repetitive, but this issue is exactly a result of the enhanced testing processes that we put in place. It's possible that prior to the enhanced testing processes that we put in place together with VA, VHA, that there could have been a miss, and somebody may have missed something that should not have been rolled out.
Mr. Case, what should VA and Oracle do to improve its testing before deploying the new EHRM functions?
Yes, I mean, clearly it has to be an end-to-end testing from start to finish of whatever the process is. It has to be as comprehensive as Oracle, Cerner, working with VA can make it. And it's that comprehensive nature of the test that where attention has to be made so that the test tests all features that are important to it.
During our last hearing in May, Dr. Elisi indicated that Oracle had already fixed the issue going forward, but that Oracle was still working with VA to do the retroactive work that needs to be done for things that were already transmitted. But we heard last week that the Pharmacy Council finally gave up on expecting Oracle to fix the corrupted data in November, 7 months after the issue was identified, because most of those prescriptions will be expiring by April of this year. Are you concerned about the message that this sends to VA providers that serious high-risk issues are not going to be resolved in a timely manner?
We are always concerned about the fact that providers must be clearly informed of what's happening and the risks and what they should be doing to mitigate against those risks. So, yes, we are concerned. The fact that it was allowed to stay in place and up until April 7th, data is still in there.
And Mr. Cecilia, we were told that part why this data was not fixed is because it would have been costly. Do you think that the VA should be expected to pay to fix things that Oracle broke?
I'm not sure that we broke anything here. This is a very complex process, and it's a byproduct of having multiple systems involved, multiple versions of Vista, multiple EHRs, and lots of interfaces in between. We are, of course, responsible and have taken responsibility for fixing all defects in the system as designed, as scoped, and on contract at our cost, and have done so. I don't believe that extraordinary circumstances for system interfaces that we do not have direct control over are necessarily things that we're billing the government for that we shouldn't be, that are not part of the scope of the existing system. So I'm very confident that we have maintained all of our warranties and fixed things that we are responsible for fix at no cost to the government.
So are you saying that who should bear this cost?
I don't have all the details on this particular issue since it goes back a very long time, and we've been making lots of fixes to the system. I'm happy to respond in writing with the details on this one.
Thank you, Mr. Chairman. I yield back.
Thank you, Representative Sherfless McCormick. I now recognize Representative Self for 5 minutes of questioning.
Thank you, Mr. Chairman. Dr. Evans, a question for you. I think we try to take human error out of everything. I'm not sure it's been taken out in this case. How many veterans have actually been harmed? Do you have any idea from these drug interactions? And the reason I ask is because I've seen returning veterans come into the civilian community taking 20 pills a day, 25 pills a day. That seems to me, I don't even know, you'd probably need a supercomputer to figure out the interactions for that. But do you have any idea how many veterans have been harmed by this issue we're discussing?
We have not found an instance of harm, though we are vigilant and looking and interested we will look to find one if we can, but we've not found an instance of harm specifically related to the drug-drug interaction issue from this HDR challenge.
Okay. Next question is, you are going to roll out Level when? The Federal Health Center, when?
The scheduled go-live is March 9th.
March the 9th. That's a couple of weeks from now. Why in heaven's name are you going to roll out a more complex system, which is not only Vista, which is not only EHR, but it also includes DOD? So is that not more complex? And we're trying to fix the complexity just in the VA?
So as you alluded, the medical center at the James A. Lovell Federal Healthcare Center is a unique medical center. It is a fully joint DOD and VA facility. There are deep interdependencies there between the DOD healthcare system and the VA healthcare system. Mm-hmm. One of the advantages that we anticipate in going live at James A. level is that we have a partner in DoD who has been able to successfully deploy the record across the rest of their enterprise healthcare system. And so I'd say a couple reasons that I feel confident about moving forward. Number one, part of the goal of the reset, one of the 3 primary goals of the reset, was to put our focus on FHCC. We haven't had we've been working to improve the system and do the enterprise work that we need to be able to successfully move forward with this program, but we've also been able to put a significant amount of attention on FHCC, and we will benefit from the DoD's experience in support of all of our users there.
Is their system exactly the same one that Oracle is doing for you?
The DoD system?
Yes.
It is the same system, yes. There are some differences in workflows. For example, at the James A. Level Federal Healthcare Center, nearly 40,000 naval recruits come through every year, and some of the healthcare they receive on what's referred to as the East Campus is a little bit different in preparing our naval recruits, but the software system that will support clinicians, whether those be VA or DoD clinicians, is the same.
Well, then all of these patches that Oracle has been doing have been done in the DoD system?
Yes.
I mean, because if they're doing this for you, why is it not, if they've already done it for DoD, why is it not the same? Because you've said the systems are basically the same. Why are we having this problem in VA?
The fixes and improvements that are delivered, so we heard referenced earlier the Block 10 upgrade.
Right.
Our block upgrades occur every 6 months. They are major software uplifts.
So these are already into DoD?
They are a
And
joint...
they work in DoD.
They're-
Why do they not work in VA?
Well, which specific ones? I mean, for example, in the Block 10, all of the upgrades that we put through in Block 10 are to the benefit of both VA and DoD. There are some that are specific to maybe a connected set of technologies that we own in VA that connects to the electronic health record, that DoD has a different set of technologies. So there's some difference, but the core system is the same.
Okay, and for Mr. Case, I want to get into the displaced appointment queue. Why are they falling through the cracks, the appointments system? Why?
Right, we do not have a root cause for the displaced appointment queue not capturing every displaced appointment, which is simply a shorthand for a provider has to cancel a set of appointments, and they have to be rescheduled. So we know that there's been workarounds put in place. Schedulers are supposed to take actions now, and the displaced appointment queue has been described to the providers and us as now a safety net. Well, it's not a very effective safety net if not all canceled appointments are going there or they disappear once there. And so we understand that VA has fixes that they're going to put into place to address the displaced appointment queue. But as it exists right now, it's still there and is not an effective safety net.
So the software can't handle it, and the human error is introduced.
Right, because of the software not being comprehensively accurate, workarounds always introduce the possibility of human error. That's correct.
Thank you, Chairman. I yield back.
Thank you very much, Representative Self. Dr. Emmendorfer, we just listened to Dr. Evans say that nothing to see here. Everything's going to be fine. We've got all the fixes in. Seems to think that the folks at James Lovell are going to be A-OK. We roll this thing out in March. It's a much larger, much more complex facility. What is your feedback from James A. Lovell and the folks there that are going to have to implement this system? What kind of feedback are you getting?
Yeah, so thank you, Congressman, for the question. So in VA pharmacy, as Dr. Evans testified to, we really have a culture of safety and quality and continuous process improvement. And not only from our Level sites, but from our other Oracle Health sites. They've done an amazing job of providing the feedback, identifying the manual workarounds that are needed, and what is needed to improve the efficiency of the system. And so one of the major enhancements that we need is the bidirectional data synchronization, the one that we've heard that has been deployed but not enabled. So the VA pharmacy community, this has been their highest ranked feature that they want to see be put in place in the Oracle Health system.
And how long has that request been out there to try and get this resolved?
I'm going to ask Dr. Silverman or Dr. Evans for the exact date.
Good morning, Congressman Rosendale.
Good morning.
The request for the synchronization, which has been referred to now as enhancements 3B and 3C, was initially targeted for Block 8, would have been February 23, was not ready at that time, and as you've heard,
February of 2023?
yes, sir.
Okay, thank you. That's all. Thank you very much. Dr. Silverman, according to Mr. Case's testimony, this is on page 4, the VHA Pharmacy Council that you chair withdrew a request for Oracle to correct the medication data in the health data repository that predated the April 2023 software update. The errors go all the way back to October 2020 when Spokane went live with Cerner. This decision was based on the expectation that all the prescriptions would expire by April of 2024, and the inaccurate data would eventually fall out of the veterans' records, which is what I referred to in my opening statement. Dr. Silverman, were you a party to this decision, and did you make this decision?
I was part of the council's recommendation for that decision, yes. And the options for correcting the existing data included, when we began evaluating it in April of 2023, a process to resend data from the Millennium Health Record to the HDR, or for HDR to correct the data. Neither of those processes existed or exist, and so if you take estimates that it would have been about a 6-month software delivery, by the time we reached November, if that software project had been started, it would have been cost, expense, and attention taken away from other efforts, such as the ones we're talking about with data.
Again, Dr. Silverman, what we're talking about is time and money, okay? And the taxpayers are continuously providing both of those. And the veterans are the ones that are at risk for all of this. And this very time and money that the taxpayers are absorbing the burden of, Oracle continues to get the benefit of for producing a product that is simply not delivering as promised or close to it. Because of this decision your council made, there are still holes today in the medication records of veterans all over the country that feed into automated safety checks. And unless every single one of those veterans' health care providers have received and understood the warning and exercised vigilance every day, those veterans are being put at risk. Dr. Silverman, do you regret this decision? And how will you direct Oracle to immediately correct the remaining errors?
Thank you for the follow-up on that. The decision to withdraw a request for a software change was accompanied by actions that have been taken. And those actions include a weekly task being operated by VA's HDR team to inactivate the older records that are in the HDR, removing all of them from the order checks, leaving the portion described up through April of 2024 to be addressed.
And these are the exact holes that I was just referencing. Thank you very much. I will now recognize Representative Shurflis McCormick.
Thank you, Mr. Chairman. This question's for Dr. Emmendorf. In our last hearing on the pharmacy issue, you indicated that it took 3 times as long to process a prescription fill in Cerner as it does in Vista. Have you seen any improvements in that time, and does it still take 3 times as long?
Thank you, Congresswoman. Yes, it still is taking approximately 3 times as long for our VA Oracle Health sites to process prescriptions.
Do you expect the upgrades in Block 10 are going to make a major impact or improvement?
We're going to have to wait for more time to go by so we can evaluate. The data synchronization piece is one that we'll be paying close attention to, because that is a scenario where our pharmacists now need to do dual entry, basically, in the MMR and the provider application to keep the data in sync.
Given most of your mitigations for known pharmacy issues calls on more labor-intensive manual workarounds, which require great vigilance by staff, what are you doing to attract and retain pharmacy staff?
Yeah. So, our pharmacy workforce, I just want to take this opportunity because we have a very highly trained, professionally trained workforce. Really, we're leading the industry and the profession. We have just under 12,000 pharmacists in our system, right around 6,000 pharmacy technicians. In our residency program, we have around 660 pharmacy residents every year that go through our training, and we're able to retain about 90% of them. They go on to become VA pharmacists. And so we're really operating at the top of our license inside of VA, so I believe that helps us attract top quality pharmacists into our healthcare system.
How are you coordinating with VHA to make sure you can add so many pharmacist staff at the next deployment sites?
Yeah. So before this hearing, was it last week or the week before, I was out at Level and spent time actually sitting through some of the training sessions to see how those worked as well, and spending time with our pharmacy staff. And so really VA's journey to a high reliability organization, I saw very good communication between our pharmacy leadership and the facility leadership. So this is a very big undertaking, and there's a realization of everyone involved at Level that additional pharmacy staff will be needed.
How long do you expect to need large pharmacy staffing?
So I don't have a good answer to that question, just to be honest, and that I think is part of our reset process, is through our reset process being able to listen to our end users, obtain their feedback. For the testing of the 3B, 3C that's been referenced, for example, it's been really important that in our pharmacy council, we're also including field representatives into that testing. So making some of those changes, but time will tell.
So my next question is for Mr. Cecilia. Does it make sense to you that modern solution takes 3 times longer to use than the predecessor, even with additional or new safeguards?
No, it certainly does not make sense, and it is not the aspirational goal of the program, nor should it be. As the doctor said, we look forward to the go live at Level, and I think at that point Level will be the first site to go live with all of the new enhancements that we put into the system since we acquired Cerner in the last 18 months. And I think that will be a very good baseline, and the feedback that we should get, and that feedback should come very quickly from pharmacy in all aspects to get to a much better process.
In your testimony, you indicated that productivity in Oracle cannot be compared to productivity in Vista because the new EHR included additional safeguards that ensure patient safety and improved health outcomes for veterans. Given the topic of today's hearing, does that assertion ring hollow?
I'm sorry, I missed the last point. Does
that assertion ring hollow?
No, I don't believe it does. Look, I don't think that there are different processes between the systems. Certainly, we're not here to say that it should take 3 times as long. That is obviously not what we're saying. I'm not a pharmacist. I'm not a patient safety expert. What should the baseline be? What are the new and how do those protocols impact staffing? That's what we continue to work together with VA and with the pharmacy councils to determine the best practice. Again, I do believe Level is the best baseline that we'll have, given that this will not be incremental fixes to existing go-live sites. This will be a brand-new go-live where all of the features will be recognized and consumed at once.
Thank you. I yield back.
Thank you. This question is for all of the VA witnesses. OIG's testimony also explains how in June of 2023, the VHA got a clinical episode review team together, and it recommended notifying all the potentially impacted veterans. They recommended notifying all the impacted veterans. This went all the way up to Undersecretary for Health, Dr. Elnahoff. On August the 7th, the team sent a communications plan throughout the whole VHA organization, including the VISNs that include the facilities using the Oracle Cerner EHR. But no one at VA ever sent the notification to any of the veterans. Dr. Evans, Dr. Emmendorfer, Dr. Silverman, how do you explain this? How do you explain this? And do you commit to notifying the veterans as soon as possible when you leave this hearing room today so that they are aware that they may be exposed to some kind of safety and health problem potentially because of interactions.
I'll start with the second part of your question. We agree wholeheartedly with both you and with the IG that it is important that veterans are full participants in their health care. They are the most important part of the healthcare team. And so informing them and making sure that we are optimizing the care that is delivered in the exam room when our VA healthcare providers are sitting with veterans, writing prescriptions, making sure that we are optimizing the awareness of those folks about how to deliver the best and highest quality safe care is very important. We agree. And we are working on communication and will communicate with the affected veterans around, frankly, many of the actions that can enhance the care delivery in the context of this EHR transformation. One of the recommendations.
Dr. Evans, this is not a really complex question.
Yes.
Okay? It's really not. All of these words that you're filling the air with right now, all I want to hear is that Mr. Case says that there's 250,000 veterans that very well may have problems with drug interactions. Very well. I can't think of another business or industry that would be allowed to perpetuate such an issue without disclosing it to their customers that there could be a problem. I'm asking, can I get the commitment? Look, I've worked with Dr. Elnahal very closely, and he has been so very responsive to everything that I have asked him to do when it comes to patient care. He really has. And so I need the three of you to tell me that we're going to make sure that we get this information out to these exposed veterans. 250,000, and Mr. Case, we don't even know what the number is potentially right now.
Mr. Rosendale, so I did use too many words. I'll make it a little bit simpler. Yes.
Thank you. Dr. Emmendorfer, Dr. Silverman, can we all work together to make sure that we get this disclosure sent out to these exposed veterans?
Yes.
According to the OIG, you notified the VA staff to be alert to the danger, but you did not notify the veterans. How can you possibly justify this when you're telling me that you're focused on making sure that we have the best care delivered to our veterans?
So first, I think with regard to, how can we justify, can you repeat the question for me so I can hear?
How can you justify not notifying the veterans of these possible drug interaction problems after you notified the VA staff? You have been notified, and how is it that you can justify not notifying the veterans of this information?
Yeah, I would, so I think most important, in my mind, the most important part is notifying the staff. So when I'm in clinic at the DCVA seeing patients, I'm aware of, and by the way, there's a clinical reminder in the electronic health record and CPR's Vista for me that would warn me if a patient has received care at one of our new sites. And so the most important person to be aware is the prescribing provider. It's the prescribing provider who's going to have to take the action to make sure that they're verifying the medication list and that they are then making sure that there are no drug-drug interactions for that particular patient. And so I agree, as I just said, that notifying the patients is important and is something we will do. It's also very important that the providers are aware of the need for the extra vigilance in this circumstance.
Representative Sherfless-McCormick, I yield back. You're welcome for your next 5 minutes question.
Thank you so much, Mr. Chairman. Dr. Evans, Of the 79 business requirements originally identified, how many did VA adjudicate as warranting change requests?
Of the 79, so we started with, as I mentioned in my opening statement, we started with the highest priority early changes that were necessary. There are further change requests that are in process for delivery, and we will be working through all 79 items and frankly, new items that we discover that are needed for improvement.
So do you have a specific number of how many have been completed and how many are still awaiting action?
I would have to take that for the record unless Dr. Silverman.
Would you know how many business requirements saw solutions in this weekend's Block 10 upgrade?
In this weekend's Block 10 upgrade, there were 3 major improvements. There were also some minor fixes as part of the platform upgrades, but 3 major improvements.
How are you measuring improvements driven by Block 10, and what's the specific criteria? Is employee satisfaction a part of that criteria?
For Block 10, yes, absolutely. Employee satisfaction is part of that criteria. I think we've spoken at prior hearings about the class survey, which is a user satisfaction or user confidence survey that we were doing once yearly. We've committed to surveying our users of the federal EHR more frequently, and the next survey is being timed specifically to make sure that we're delivering that survey after Block 10 so we can assess in a robust way the satisfaction of our end users with the Block 10 improvements.
And what is your timeline for these measures?
For the user satisfaction survey, I can certainly get you the official timeline. I think we were going to wait at least a month after Block 10 to make sure that folks had had the full experience with Block 10 before they were asked to comment on their satisfaction with it.
Mr. Case, the OIG has been watching this program closely from the beginning. Have your people observed any improvements in the program management? What are their biggest issues that the VA needs to address to improve its management of this program?
Yes, we have seen an improvement in the sense that the senior leadership, some of which is right here, we find to be receptive to issues that arise either from us or other areas and committed to resolving them. And we need, and we think that going forward, there needs to be enhanced project management to get VA through the reset and out of the reset, including accurate measurements as to whether the reset is successful and achieved its goals. And then once that's done, the real work of project management occurs in large scale to try to assess how to go forward once you're out of the reset.
Repeatedly, OIG and others have found that the scheduling and pharmacy staff in particular have found themselves overwhelmed when using the system. In part, this appears to be due to insufficient or inadequate training focused on day-to-day usage of the system. VA has modified training plans previously, but it's clear that these efforts need to be stepped up. How did you train staff differently at Lovell, and how are you measuring training success?
That question is for me. I'm not implementing the training program at Lovell. We do need VA, and I understand they will be measuring the success of that program.
That was for Dr. Evans.
Okay, I thought so. So yes, we've, so first of all, at Lovell, we have introduced several new, we've changed training. As you mentioned, right, it's important through training to learn how the software works. But what we've heard consistently from our end users is that understanding how the software works is not sufficient. It's really to deeply understand how the software will work in their day-to-day work. And so understanding how can I configure this software for optimal use, saving favorites to make things more efficient for me when I'm seeing a patient in my type of clinical medicine, what are the best practices? And in support of that, we've added some new, I'll call them adoption activities at FHCC. I think sometimes when we think about training, that's oftentimes an online training class or sitting with an instructor in a classroom. Most of us as learners, we learn, yes, we learn in a classroom, yes, we learn online, but we really learn by doing and trying. And one of the new events that we've gotten great feedback from at the FHCC site is what we call our learning labs, where we allow users to really practice their full work in our sandbox environment. We also are going to be able to bring even more what we call pay it forward, peer support at the time of go live to improve our ability to sort of stand at the side of each of our end users in helping them adopt the new solution.
I yield back. Thank you.
Thank you very much, Representative. Pay it forward? Pay it forward? Is that what you just said? We've been paying this forward for 5 years now to the tune of $9 billion. $9 billion. And quite frankly, Dr. Evans, I find it disingenuous to blame this on training when the users, okay, you're saying they have to be more comfortable with the software. It is disingenuous to try and blame this on training and the users when they cannot even rely upon the data and the information that they're receiving from this software program. Representative McMorris Rogers, are you ready, or do you want me to give you a dive in? Thank you so much for joining us. I now recognize Representative McMorris Rogers for 5 minutes of questioning. Thank you.
Thank you, Chairman Rosendale. I really appreciate you hosting this important hearing today and giving me the opportunity to address this committee. The Oracle Cerner electronic healthcare system has been a disaster for the veterans it was designed to serve. We're familiar with the devastating problems the EHR has created for veterans, especially in Eastern Washington, where it was first launched. Problems were clear from the beginning. Prescription orders and referrals disappearing into unknown queries, long outages making the system useless, dropped appointments and other errors directly harming nearly 150 veterans. Things have gotten so bad that some veterans have been told to work around the system altogether, to call their local pharmacy rather than use the EHR to do something as basic as filling a prescription. It's hard to fathom that the system was so broken that our VA pharmacies cannot serve their sole purpose. But that's exactly what happened, and our veterans are paying the price, accumulating hundreds and sometimes thousands of dollars in debt after being forced to pay out of pocket for treatment. At Man Grandstaff, pharmacy employees continue to work under extreme pressure, relying on memory to recognize dangerous drug combinations and other problems the system is failing to catch. Burnout and low morale have become the new normal, adding pharmacists to the list of providers and support staff that simply can't take it anymore. Their leaving is making bad staff shortages worse, creating longer wait times and making it more difficult for veterans to get the care that they need. It's unsustainable, and the EHR is to blame. Let me be clear. The time for an action is over. We owe it to our nation's heroes to get this right. And I believe that starts with pulling the plug on this deeply broken system and going back to one that works. That's the only way to restore broken trust and help our veterans who have nowhere else to turn. Our witnesses here today will play a vital role in achieving that goal, and I'd like to ask a few questions. Dr. Elmdorfer, you represent the pharmacist, and they've reached out. They've really reached a breaking point in Spokane and other medical centers that are using the Oracle Cerner EHR. So I'd like to ask, what are they telling you?
So this last September, we had a pharmacy leadership meeting. And during this reset period, Congresswoman, one of the things we're trying to do is just ensure that we're hearing the voice of our end users and of our pharmacists. So our chief of pharmacies from there, and Sonny, who's our chief in Spokane, it's really, it's because of his leadership that he has, that it requires more staff. It takes 3 times as long to process prescriptions in the Oracle Health system. And it's really, they're dedication to the mission of caring for the veterans to ensure that we're still able to get the prescriptions to the veterans that they need. And it does require more staff. There's manual workarounds that the staff do have to use, like you referenced. We are aware of those. And so during this reset period, it's important that we get as many of those issues addressed for our pharmacy staff.
Thank you for that. I guess I would, from your perspective, what needs to happen with the pharmacy software in order to avoid a breaking point?
Yeah. So earlier we were talking, and VA pharmacy has this culture of quality and safety and continuous process improvement, and those will continue to be our traits in VA pharmacy. So first of all, it's our healthcare providers delivering the care that provides that high quality, and the electronic health record, regardless of what it is, needs to support that delivery of care. And on that journey, one of the things that we do also need to do is get back closer to a baseline productivity.
Okay. Mr. Scalia, the men and women who work in our VA pharmacies are at the end of the rope. And I'd like to read to you what one of the pharmacists in my district had to say about the Oracle Cerner system. Quote, "I cannot do this anymore. The stress of this system, added workload to make it function. I cannot care for my patients and have stopped being able to care for my own well-being." What am I supposed to say to someone who's been destroyed by the system?
Well, I certainly acknowledge that there have been issues in the pharmacy system and in the system in general. And since we took ownership of this contract, I do believe that we have made improvements. And I'll speak in two phases there. The first is the system, as you mentioned, when we took it over, was unstable, was unacceptable. There were 5 SLAs. We signed up for 23 in the new contract, and we've largely met them and paid financial penalties when we did not meet them, and we'll continue to do so in the future. Pharmacy has been, and in the federal enclave, the one thing that's different between the VA and all of the other tenants is pharmacy. It is a unique process, and it has been the most difficult and the most challenging to get it right. I do believe with what we're about to roll out at the Captain James A. Lovell Federal Health Center in North Chicago, we will see the benefits of all of the focus that we had to improving pharmacy. I still don't believe, and I'm not here to say that that equals success, and that equals a baseline or a productivity goal that we want to say that's all we can do and we'll move on. I do believe, though, that the move towards standards, the move towards better testing and better, better reliability will yield better results for pharmacists. And I think the evidence of that is in a function for pharmacy, the 3B, 3C, that we didn't roll out this week. Not that we did, even though it was scheduled to be rolled out. We didn't roll it out because it did not pass all of the safety protocol tests. That is a difference between what may have happened in the past versus now. Now, it has been fixed, and it has been addressed, and now it is in testing, but we caught it. We caught it. And that is, I think, a big difference between the way the program used to work and is working now. I do believe that there are better protocols and better functional testing in place to make sure that we don't make pharmacists' lives more difficult.
Okay, I appreciate that. However, the veterans in Eastern Washington feel like they've been left behind in the midst of all of this. This health record first new record was rolled out in October of 2020. And I've yet to hear the plan for how we're going to make it work and make sure that our veterans get the care that they need. With that, I yield back.
Thank you very much. Forgive me if I don't celebrate, because we should commend you for not rolling out yet another failed update. Representative Schneider, I recognize you for 5 minutes of questioning.
Thank you. And first, I'm grateful for you allowing me to be a part of this hearing. I represent the 10th District of Illinois. Lovell Healthcare Center is not just in my district, it's central to my district. It's critical to the veterans in the 10th District of Illinois as well around the region. I'll start, I'm not sure exactly I'll start with you, Dr. Evans. I'm not sure the right one, but Lovell we are the first, and so far the only, joint DoD VA hospital, which makes the March 9th rollout a little bit interesting, because it's the first time we're trying to do it over this bridge. Can you talk about what steps have been taken to make sure that it's going to be rolled out effectively without a discontinuity or breakdown?
Sure, I'd be happy to. First of all, I have had the privilege of traveling relatively frequently to North Chicago, Illinois, and to the James A. Lovell Federal Health Care Center, and I have to say that it's a really special facility.
I agree.
And its mission is really compelling. On top of that, the staff at the James A. Lovell Federal Health Care Center are committed to delivering outstanding care to service members, beneficiaries, veterans. It's the one VA medical center you go to with a pediatrics clinic. It's a pretty interesting place.
Special place.
And because of that, we have needed a significant level of focus on FHCC, including some of the complexities that you are well aware of that are introduced by trying to run a joint DoD-VA facility. There are a lot of eyes on James A. Lovell, from the Federal Electronic Health Record Modernization Office, which is leading the deployment, to the 2 program offices in both DoD and VA, who are really putting a tremendous amount of resources, to Oracle Health and the Leidos Partnership for Defense Health, as well as the Defense Health Administration, VHA. But when it comes down to it, we are all there to support the staff on the ground at FHCC. Success at FHCC is our commitment to those 3,200 staff who come to work every day to care for those who are served by that facility, and that's really been where we've anchored our attention.
Thank you. Let me turn to Mr. Cecilia. Listening to the testimony here, I'm getting, I guess, the technological equivalent of PTSD. 40 years ago, I worked in systems development. It wasn't the team I worked on, but one of our office practices in New Jersey installed a new system to the DMV, and when it went live, there was a 4-second delay between every keystroke. It worked well in testing, it didn't work well in implementation. You've talked about some of the challenges of a system that you acquired and inherited and trying to make those fixes. There's fixes that are dealing with efficiency, and we've heard some of that today, the concerns about efficiency and just making the job better. And there's concerns that relate to patient safety. And one of the things that impressed me in Dr. Evans' testimony is the idea that the pharmacists are an integrated part of the care team. And I think that's something that we owe all of our veterans, is the best and not just the most professional care, but the safe care that delivers on their needs. What confidence as we go to this live rollout in Lovell next month can you give us that we're going to support the teams on the ground? They're going to be able to continue to deliver the level of care they historically have, if not improved, and that the bugs that have been harming the care of the system in the past won't be there in the next round.
Sure. Well, I think your characterization is correct. There are 2 buckets. There's system reliability and availability, and then usability, being able to use the system. And as you mentioned, when we acquired the system, it was not reliable, and it was not at a functional level that I think we could warrant that it was an acceptable experience for end users. And we've largely addressed those system reliability issues, those issues that sort of keep the plane in the air. I mean, if you can't do that, then the rest of it really isn't going to function well. And now we've turned, as Dr. Evans said, our full attention during the reset period to making Lovell the best rollout and the best experience that it could be. I do believe that Lovell will benefit from all of the learnings we've had in both of those buckets, both the system reliability standpoint, the networking standpoint, things like printing and all those things which are very important inside a system, as well as the functional enhancements. There are lots of functional enhancements that have also been made beyond pharmacy, over and above pharmacy. That Lovell will be the first site to absorb everything at once. Well, they will get the best of the new system at one time. The other 5 live sites have had to take these functional enhancements piecemeal because they were already live and they were already already functioning on a system that, admittedly, when we took it over, was not stable and was not acceptable. So I think their experience has been very different than the experience that Lovell will have as a result.
Well, thank you. We'll be watching. We're counting on it. Sticking with your airplane analogy, it's not just getting the flight airborne, it's getting us to our destination safely, but it helps to be on time and without bumps and bruises. So with that, I yield back.
Thank you very much, Representative Snyder. Dr. Evans, the big ticket item in last weekend's software update was supposed to involve automated coordination of prescription information between PowerChart and MMR. But you postponed it because it had too many errors in testing. What were the testing errors? What problems would they have caused? When do these errors have to be corrected in order to avoid causing problems at level? So what were the problems? What issues would it have caused for our veterans? And how can we make sure that we don't have this problem introduce a virus at level?
Right. So let me just describe quickly what the capability was to do. When a physician or a licensed independent provider writes a prescription, that prescription is then sent to the pharmacist who's going to process that in a different application called Med Manager Retail. And that pharmacist, as part of the normal practice of pharmacy, is going to adjust that prescription if there's a need to adjust it. Maybe a certain strength of the tablet is not in stock at the pharmacy, and so instead of issuing a 20 milligram pill, we have to issue 2 10 milligram pills. Maybe the provider spelled something wrong, and the pharmacist is a better speller and can correct that on behalf of the pharmacist. But the pharmacist will adjust the prescription. And that information then should be, in a commercial healthcare system, the pharmacist may fix that at a commercial pharmacy, and it doesn't synchronize back to the electronic health record that the provider is using. But in the VA, our expectation is that those changes the pharmacist made are now visible to the provider, so that the provider knows exactly what the patient was given, and so that when the provider a year later renews that prescription, again, they're now renewing the appropriate prescription, which means the pharmacist doesn't have to redo the work of fixing the prescription that would have been renewed if it was the erroneous initial one. So that's what the software is supposed to do. And it worked for all of the normal circumstances. A single pill that was 2 pills, correcting the spelling mistake. But there were some places in testing where a non-traditional insulin regimen or an inhaler where the strength of the inhaler was a unique strength of the inhaler. So, it was not most of the cases. Well over 95% of the cases, I don't know the exact number, but it was a high percentage, were just working fine. There were these sub-cases where we recognized we needed to address those issues. Our expectation is that it will be delivered, as Mr.
So this small number of cases, is this 250,000 that we're talking about?
No, it's an entirely separate issue.
Okay.
Entirely separate issue. And so our expectation is that the fix has been put into testing. It is now being tested as of today. And our expectation is that we will deliver prior to the FHCC go live.
Dr. Evans, this is closely related to the update that Oracle launched, and then you quickly turned off last April. Why has this particular issue been so difficult to resolve?
I think in part because of, we're dealing with, this is one consolidated set of technologies, but ultimately 2 different information systems that we're asking to coordinate with each other. And there are some technical complexities there. Also, some work to identify what the issue before was that we realized that there was one field that wasn't synchronizing that needed to be better synchronized. But I'll let Dr. Silverman can probably comment to that more accurately.
Thank you, Dr. Evans. Chairman Rosendale, as you've asked during this hearing, the initial plan on Enhancement 3B was scheduled for Block 8, February 2023. Oracle Health identified an issue and made the decision not to deploy there and moved it to that April cube in 2023, which was right before our previous hearing.
So why is this particular issue being so hard to address?
I don't know that I know the answer to that other than when the Oracle
Okay,
tech team.
if you don't know, that's fine. Dr. Emmendorfer, the 5 medical centers using the Oracle Cerner EHR have had to increase their staffing by at least 20%. We've been discussing that. Manage all workarounds. And I understand that your office estimates that a large, complex medical center would have to increase its pharmacy staffing by as much as 60%. Give me a rough estimate of how many staff have been added so far and how much this costs annually, if you could.
Yeah, so right now at our smaller sites, the complexity 2 and 3, on average, it's been about a 20% increase in staffing. I don't have the exact FTE, the staff numbers, but that would equate to, as far as cost, I don't have an exact number, but it would add millions to our staff, to our salaries.
Okay, thank you so much. I yield back and
Thank you, Mr. Chairman. I wanted to go back to our questioning on education and training. So my question is going back to Dr. Evans where we left off. How are veterans and caregivers being educated on mitigating the issues the OIG identified with inaccurate medications and allergy checks at legacy sites?
First, I think it's important, in JLV, which is the application where it's the application where VA providers would go to look to see a consolidated medication list. That is, medications that were prescribed at the facility where they're seeing patients, as well as medications at any other VA facility, as well as medications prescribed by the DoD, including in the federal EHR, which is in use at the 5 sites that we've mentioned. In JLV, the medication list is an accurate medication list. Also, the first thing is that it's important, we emphasize with all patients in any of our visits the importance of what we call medication reconciliation. This is an important part of healthcare in general. It is making sure that we have an accurate medication list. Is the veteran taking any medications that we don't even know about in the VA because they were prescribed by a commercial provider and fulfilled at a commercial pharmacy? And so it's through that process of medication reconciliation that then that foundational medication list can serve as the guide for now as I'm going to prescribe or add a new medication to that list or change a medication that I understand whether there's any interactions there. And so the primary thing that we've been emphasizing with patients is the importance of bringing your medications to your visit, make sure that we spend the time getting an accurate assessment of what you're taking, including over-the-counter medications, herbal medications, supplements, et cetera.
So that medication reconciliation, that's part of normal healthcare practices throughout the industry.
Yes.
But now with this increased level of inaccuracy, are you taking any other steps, further steps to make sure that they're aware, caregivers and the veterans are aware of, or are you still doing the regular medication?
Yeah, I think what I was trying to get at is medication, to your point, medication reconciliation is fundamental to good health care. And as Mr. Rosendale asked, are we going to notify veterans and communicate with veterans?
Yeah,
and
precisely.
we responded to that in the affirmative.
Are there any extra steps you're taking? That's what I'm really asking, in light of these inaccuracies.
Right, so the issue for the subset of individuals, which is a increasingly shrinking number of individuals who might have this challenge where the automated drug-drug interaction checking is potentially inaccurate or could be inaccurate. There are other ways for a provider to be able to check for drug-drug interactions. As an example, in clinic, whenever I'm concerned, we have a national contract with a web-based solution that can help providers get access to trusted clinical information, and it has a very, very good drug-drug interaction checker in it. I enter the medicines that the patient is receiving in that drug-drug interaction checker and actually get, frankly, more valuable information from that on the specific interactions when I'm making those decisions. So providers are having to do that manual step. Actually, frankly, many providers would do that anyway.
That's not a required manual step, correct?
That's correct.
And that's not a system that's in place, correct?
That's what?
It's not a system that's in place throughout the entire?
There is a national contract for that drug-drug database.
Okay. So my next question is, how are you ensuring legacy site providers and pharmacists know that these issues exist with respect to inaccurate, duplicative, or missing information?
VA providers and pharmacists. A notification was sent to facilities about the issue. In addition, as I mentioned, some facilities have implemented what's called a clinical reminder to provide real-time clinical decision support to providers when they're prescribing medications.
Dr. Evans, Oracle use of cues has come up again and again. Has VA done an evaluation of all the cues to identify any other issues?
So this is, I think, referring to the displaced appointment queue that was mentioned in the IG testimony. With regard to that specific issue in December, the fix was entered into production to make sure that we can support the number of contact attempts that VHA policy dictates after certain no-show appointments, particularly for mental health appointments. As for management of queues, I think inherent in the delivery of healthcare and delivery of healthcare to large populations are making sure that we are managing the list of individuals who are waiting for any given service. And so, yes, we have spent a considerable amount of time making sure that we understand any queue that needs to be managed in support of veteran healthcare.
Thank you so much for your testimony. I yield back.
Thank you so much, Representative Sherfless-McCormick. Dr. Emmendorfer, I want to go back to the additional staffing that's going to be required by the pharmacists to accommodate this system. Right now, the total spend on pharmacists, my understanding is that it's $2.7 billion. That's annually, correct? $2.7 billion annually. If we have a 10% increase, in that spend, that's $270 million. If we have a 20% increase in that spend, that's $540 million. That's nearly $500 million. Dr. Emmendorfer, your office is developing a pharmacy staffing model for future medical centers to use to figure out how many positions they will need to add based on all of this. This is based on an assumption, and I think it's an absolutely correct assumption, that the Oracle Cerner pharmacy software will continue posing these difficulties, and the medical centers will need extra staffing for the foreseeable future. How does that staffing model work, and who's going to pay for all the extra pharmacy staff?
Yeah, I can speak to what we're doing with the staffing model because we do need to develop a resource. When our Oracle Health sites first went live, there wasn't enough data points to develop a reliable model. So maybe a month and a half ago or so, we convened a work group that includes representatives from every level in the enterprise, including staff that are using the Oracle Health system, to help us try to define some of those parameters. And right now, because of the number of manual workarounds, the processes vary because of the manual workarounds, and we're still working on, and we still have a goal of trying to develop the model, but we do need to see some standardization to develop that staffing model. So some of the areas that are kind of new inputs for our staffing model that we need to consider is there's multiple queues now in Oracle Health Cerner, and I think there's like 5 or so. Mm-hmm. And each of those queues could range anywhere from an extra 5 to 20 or 40 hours of different staff time per week. It's a process, an outpatient controlled substance for one step of that process, like an additional minute could occur. And then with our controlled substance inventory system, that's something we need to maintain for Drug Enforcement Administration to have those counts. One of the manual workarounds that our staff has is that they have to stop the production while those counts are done because of the way that the system decrements the inventory, so that causes a slowdown. So once some of these things start stabilizing, we definitely have a goal of developing that resource and finalizing it for the future.
So what we are talking about, though, just to make sure I understand completely, is not that it's a lack of training on the pharmacist's behalf. It's the fact that the system itself requires additional steps which we call workarounds. I hear you reference workarounds many times. It's additional steps in order to get to the same place, which is consuming this additional time and requiring all the extra work.
Yes, we have a highly trained VA pharmacy workforce, so we know how to act and perform in the profession of pharmacy.
Thank you so much. Mr. Case, I want to go back to one detail in your testimony. We did not recognize the enormity of this until your office briefed the committee staff. Previously, VHA staff were required to make 4 attempts to contact veterans for mental health appointments. And this is very, very serious because we all hear about and want to reduce the number of veteran suicides that are taking place, the 22 per day, because the consequences of not getting this care can be so damaging. But when the Oracle Cerner EHR was implemented, that was reduced to 2 attempts because of the burden of documenting these calls or letters in the system. Who made this decision, and how could an IT system drive a policy decision that can have life or death consequences? I have here in my hand the VA policy that says that it's, let me see here, Directive 12321 in parentheses, and number 4 on page 2 says, for mental health appointment, the minimal scheduling effort for scheduling, rescheduling totals of 4 attempts. And then it describes how those 4 attempts are to be made. Could you tell me how and who made the decision about reducing that to 2 attempts, and by what authority did they do so?
Yes, we believe it's a combination of things. First of all, the decision was done by the Office of Integrated Veteran Care to do the reduction. And you combine that with the directive that where the new EHR is in place, then that's the rules for the new EHR predominate, so to speak. So the staff followed the rules in the one instance in our report and made 2 notifications, but they did not have the extra step because 2 more notifications were not made. And so, our view is that this is a problem, and first of all, the lesser number of notifications, but second, you really is setting up a system where there's 2 different approaches to the same issue. There's different healthcare efforts in whether it's in the new.
So did you find any place where the rule and the policy had actually been changed? Or is this just a decision that was handed down? Because I haven't found it.
Yeah, this is what happened. Once our report is published, we'll describe the exact details, how it was done, but this is what happened. This came up an incident in Columbus, Ohio.
Thank you. Thank you so much. I will now recognize Sheriff Alyssa McCoy. Thank you.
Thank you, Mr. Chairman. This question is for anyone who would like to answer it. How would you measure the success of level FHCC Go Live, and are you confident that it will be successful?
Thank you. Thank you for the question. It's obviously the key focus of what we're all working on here together. I think we have lots of benchmarks and lots of inefficiencies and things that have been measured in all of the other go lives, most of which are not favorable, most of which experience difficulties with staff engagement, with training, with retention of the training, not being repetitive and not being available on demand, as well as general overall system performance. So if we compare level to the go lives at the other site, we should see a marked improvement in satisfaction. We should see a marked improvement in system reliability. And we should also, I think, be in a position, as the Pharmacy Council has testified, to figure out how much extra staff is required for the long term. Because what is unusual, it's not unusual that when you have a major go live for a very complicated system, that extra staff are required. This happens in commercial markets. This happens all the time. What is unusual is that you have to sustain that staff for a long period of time. So I believe that the metrics and feedback that we will get very quickly after the go live at level will put us all in a much better position to determine that issue for the future as well. I am confident that the go live will be successful, to directly answer your question as well.
Thank you.
I can answer that question as well. I think
Yes.
it's important to remember that there have been challenges with regard to health IT at the James A. Lovell Federal Health Care Center. They've been running 2 different electronic health records, including maintaining custom software to try to keep those 2 electronic health records talking to each other while trying to run a single joint facility with a fully integrated staff. And those challenges have been long documented, and I remember traveling to FHCC, I think in 2019, and they were very, very eager to move to having a single integrated electronic health record. And so one measure of success is that some of the challenges that they've had in running 2 electronic health records are improved in running a single integrated electronic health record. There are still going to be issues because there are different workflows unique to the DoD versus the VA. Pharmacy benefits are different in VA versus DoD, but having a single record will be important. And the other area where I would measure as success is whether the 3,200 approximate users there feel better supported than prior users have in this transition. That is, are we committing to supporting those users as they navigate the journey to use the new software, not just in a couple weeks after go live, but in the months to follow and frankly years to follow.
Thank you. I wanted to go back to Mr. Scalia. I want to pick up from where you left off when we were talking about the success. So far with the go lives, what do you feel have been the biggest causes of it not being successful? And what could the VA do to support Oracle?
Well, in the initial set of go-lives, I think there were system reliability issues that made it very difficult for end users to feel comfortable using the system on that it wasn't going to have an outage or something like that, and that's that was not good. But as Dr. Evans said, I do think that the human element, I think the standing shoulder to shoulder and making sure that we have that support for a much longer period of time than we had at the initial go-lives. The lesson learned is that we need to be there longer, we need to be on site longer, we need to be next to the providers longer, and we need to be rolling out fixes for feedback far more quickly than we have. And I believe that those things are in place. I believe that we have absorbed the lessons, and we've been listening very closely to all the providers, to all of the councils, and I do believe that prior to previous go-lives, which were largely handled, frankly, before most of us were involved with them, that the collaboration between Oracle and the VA and the VHA, as I've testified before, is the best that it's ever been. I'm very optimistic in our collaboration. I'm very optimistic in our daily and somewhat daily meetings for specific issues like pharmacy happening right now, as well as our continued sync with the DepSec and others to make this happen. I do believe that the team, all in together, is better than it's ever been, and I do believe that we will see results of that in the Lovell Go Live.
Thank you. I yield back.
Thank you very much, Representative Sherfless McCormick, and I want to thank everyone for participating today. I just want to close by saying that we're $9 billion and 5 years into this system, and we still don't have a functioning system. We don't have a fully functioning system. Here's a nice list. Here's a list of contributions that Oracle Cerner has made to people that are serving in this body. And I wish that you invested as much time, effort, and money into getting that system straight as you have in trying to buy votes on Capitol Hill. With that, I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, this meeting is adjourned.